Our next distinguished speaker is Sarah Glastras. Dr. Sarah Glastras, who is not Greek, by the way, she clarified that earlier. She's married to a Greek person, is a clinician researcher who works as a staff specialist in endocrinology at the Royal North Shore Hospital, Sydney, and a postdoctorate fellow at the Colling Institute, University of Sydney. She also consults in a busy private endocrinology practice. She holds an NH and MRC Early Career Fellowship to further extend her research on the role of maternal obesity in predisposing offspring towards chronic disease. She has continued her research to unfold the mechanisms underlying fetal programming of obesity. In addition to her basic science research, she is involved in many clinical studies within the Department of Endocrinology at the Royal North Shore Hospital in the areas of diabetes and obesity. She has a particular interest in the evaluation of diabetes and obesity services within the local health district. Please welcome Sarah Glastras.
Embedding research and evaluation into clinical obesity care needs a bit of unravelling, so hopefully I'll take you on that journey with me. First of all, my disclosures. So to start with this question, what is clinical obesity care? You can take that quite broadly. So you can look at prevention, case identification, who has obesity, coming through clinics and seeing us in our practices, to treatment. And with respect to all of that, we've got a lot of players. So we've got public health, primary care physicians, allied health and tertiary care providers. So I think that's important to just keep in mind that where I'm going from here is much more about the treatment angle of things, but I think bearing in mind that actually that should encompass a whole lot more than just treatment. So you can see here, we've talked about this already this morning, about essentially the treatment options that patients have for obesity. And that can start with lifestyle and behavioural modification, going through to very low calorie diets, anti-obesity medications, and then the very tip of the iceberg there is really our patients who are receiving bariatric surgery. And you can see the BMI alongside there, and I think after the talk this morning that should be changed to both class and stage as a guider of who really requires the intervention and who gets to that pointy end. So we've seen both of these slides so far today, so in terms of the graphs, and so I think what is important here is I'm really picking out those studies that have actually shown longevity, so that we've got the scale study here with liraglutide medical management, taking that through to 3 to 4 years. So staying on drug, so to keep in mind this is not patients that just took it for 6 months and then stopped, but patients who have continued on liraglutide for a good 3 years have maintained their weight loss. I think to George's point, you've got that Nike tick there, again demonstrated with liraglutide, even though these patients are staying on drug. But at the end of the day, there's still 7% body weight loss versus less in the placebo. And we've seen this as well this morning with respect to the Swedish obesity study group, showing that surgery is also effective at maintaining weight loss long term, so taking that out to 20 years and beyond, but again with some weight regain. So this is a map of Sydney and socioeconomic status in Sydney. And if you live in Sydney, it's no surprise that here is sort of central Sydney and the northern suburbs of Sydney, where socioeconomic is really in the top 20% of the country. Whereas come out further to the west of Sydney, where Evan and Rami are working, you're seeing here is really the socioeconomic disadvantage that we see within Sydney. And then if you superimpose what you have in terms of obesity rates, then you can see that actually is pretty much a mirror image of that. So socioeconomic background is really also related to obesity. And so when you're then talking about clinical obesity care, that's clearly got to influence where you're going to put your services and where you're going to target your group. So with respect to the clinical obesity services in public hospitals, so I was involved with many in the audience here, and with Evan as leading this initiative, of looking at the clinical obesity services in Australia. So of 16 services across the country, that really it covers about 86% of where Australians are living. So still a proportion of patients there that really have absolutely no access whatsoever to clinical obesity services. services. And these services really are only seeing a small amount of patients. So we saw before that severe obesity is beyond 1 million patients in our country, but yet these services, 16 of them, are seeing less than 10 a week. So clearly we are only seeing the tip of the iceberg. And mostly are reserved again to severe obesity for good reason. It's about access. There's long wait lists, and most of these centres have more than 300 patients sitting on their wait lists. And there's often an out-of-pocket expense, even though patients are coming to a tertiary hospital often service for things like very low-calorie diet, medications, etc. And unfortunately, only 60% of these 16 services have access to what you would consider common sense in terms of providing care to obese patients, things like nursing, psychology, clerical staff resources to actually contact patients, get them in, write letters, do all of those things that are related to that activity. And less than 50%, which is again really an alarming statistic really there, that many of these services don't have any exercise physiologist or physiotherapy involvement. And only a third are providing weight loss pharmacotherapies, and as I said, often they're costing the patient out of pocket. And within all of these various services across the country, there is great heterogeneity in what is being provided, again leading to inequality and inequity. And this is a finding of the study, and what you can see here is the currently available resources in the centres, and this is really up here in this side. Dietitian, physician, bariatric surgery, lifestyle intervention. But the wish list is over here, and the very few of the services are being able to provide weight loss pharmacotherapy, a multidisciplinary team with the psychologist and all the others that are involved, exercise physiologists, and actually a surgeon to attend those actual clinic visits. Okay, so what are the key features of a successful obesity service? And that comes down to, if we're going to embed research and evaluation in what we do, how do we actually assess that? So these are a few ideas. Body weight loss, so hopefully the end game is actually achieving weight loss in our patients, improving comorbidities, metabolic, mechanical, psychological, improve quality of life for patients, and then cost effectiveness. And how are we going to do that? Well, here is a way of I guess, defining those things. Of body weight loss, that's pretty straightforward. Metabolic complications listed there, physical, psychological, social. Again, drawing that down further, you've got to work out, well, what is the test that you're going to use? What questionnaire you're going to give your patients? Is that valid? Has that been reproduced? And is it reliable? And then cost effectiveness in terms of the total cost of the obesity service versus the total health gain. And that health gain, again, is sometimes very difficult to really nail down, and it can be hard coming up with, well, is it just about how many knee operations you've avoided? Is it to do with all those other things about productivity, quality of life, all of those in there as a cost analysis as well? So I think really, at the end of the day, an ideal system is an integrated care model. And this concept of integrated care I've really borrowed from our diabetes colleagues and from cardiovascular health and cancer health as well. That really integrated care is about having a network of organisations that provide a coordinated continuum of services to a defined population, and that they're willing to be held clinically and fiscally accountable for the outcomes and the status of those patients. And it should involve all levels of care, right from primary through to tertiary and beyond to long-term term health. So I've got 5 minutes left, so I'll just go through these slides fairly quickly. But just in terms of integrated healthcare delivery, I think what is really important there is that you've got to be matching the service capacity to the community needs, and that relationship and feedback from the actual community that you're delivering the service is very important. So the stakeholders of consumers, providers and payers then become incredibly important. And cost, quality outcomes and customer, or I guess consumer satisfaction is really important. And it wants to keep on re-evaluating itself, and that's how an integrative care model should be set up. And this is a systematic review of what an integrated model should look like. And so we've got an interdisciplinary teamwork approach, which comes down to that point of, can we actually get the resources to have those staffings that we need to provide this sort of care? Communication, information exchange, shared guidelines and pathways, and we can see that we're starting to develop that in Australia. Training and education, access and acceptability for patients, and then viable funding model. And so to be able to sustain an integrated care model, you have to have funding to enable this to go forward. And that seems to be a major problem for us all across the country. So introducing what we do at our centre at Royal North Shore Hospital. So this is the SHAKE clinic, and the clinical lead for this is Dr. Lucy Ding, who unfortunately couldn't be here today. It's a tertiary hospital setting, obviously, and it's funded by existing resources within our department. So we are, basically trying to run this on the fly without adequate, really clerical staff support and the rest. And really this idea comes from a shared health appointment model, which includes the patient, obesity specialist, educator and dietitian, educator in the setting of somebody with diabetes, which predominantly is what we're seeing. And it's a finite experience, so we don't have patients coming into this clinic and just staying in there for years and years. It's 6 months of SHAKE clinic, and then an option to come back at the 12-month mark for review. And it's a bi-directional interaction with the primary care provider. We're seeing 4 to 12 patients at each shared medical appointment, and this idea is really to encourage questions, sharing concerns and experiences between patients, and really individual issues are addressed, but also there's that possibility of feedback with other patients and learning from their questions. Confidentiality is ensured, so a confidentiality agreement is signed by the patients, and it's endorsed by New South Wales Health, so therefore in terms of billing and napping and all those things that we do at a tertiary hospital level, we have that capacity to do that. And of course, the benefits are beyond just being able to have a larger group attend at the same time, because part of the initiative was really we had wait lists of over 300, 400 patients, so it's significantly reduced this in our centre, but it also provides more than just that in terms of the feedback that patients have with each other and with the clinicians involved. And so this is the idea of the model, really, that we've got the SHAKE clinic and the very low calorie diet, which is what we're setting this SHAKE clinic, that's the treatment, is essentially very low calorie diet, with at the end of that time really a review of an individual SHAKE outcome, but also an audit of the outcomes of the whole group, as well as then triage referrals beyond that. So back to allied health, to the GP, other physicians involved in that patient's journey, and then the possibility that via this SHAKE clinic they eventually enter the one-to-one bariatric clinic clinic that we offer. So that is really the point where we move to a bariatric surgery wait list, because we don't want to end up having a patient who really hasn't gone through this whole process, who ends up actually on this wait list, and then when it comes to their turn they say, actually no, I'm not ready to have surgery, thanks very much, or they haven't gone through the right process. So we're hoping to evaluate this, which is leads me to the protocol which we're setting up this SHAKE clinic under. So really we want to be able to evaluate the service that we're providing. As I said, really body weight loss is what we want to achieve, but beyond that it's actually improving clinical indicators, access to other services and quality of life. And we've power calculated that we need about 260 participants to be able to demonstrate efficacy of this program. And you can see that we've set the bar a whole lot lower, so BMI above 27 with diabetes, or a BMI above 35 without diabetes, just so we can increase the access point and be able to provide service to more than just a few. And we're hoping to then roll this out so that it goes beyond just the hospital setting, but we'll set up SHAKE clinics out in the community, not just at the hospital. I'll skip that because it really isn't a whole lot of point showing you. It's only early data of our SHAKE clinics, but just to say that dropout is something that we see a lot of as well. So attendance rates by the end of the time we get to 6 months has almost got down to 50%. And just to point out again, that capacity is a huge problem. So this is the time that it's taking the facilitator to set up all of this this new system, and then the dietitian doing calls and responding to emails and making sure the research is going. We're collecting the data, putting it into REDCap, setting REDCap up. All of those things just take an enormous lot of time without any proper funding. And here's some specific population groups that I think are underrepresented in the studies and in what there is available in the literature. That young adults are a special group. I've put kidney transplantation here, but I'm sitting next to Kathy Samaras, so I was thinking really it's not just kidneys, obviously things like heart and lung transplants as well. So they're a specific group that I think we need to be able to provide evidence for benefit in those patient populations. A group that's close to my heart, which is because I do a lot of my basic science and clinical science in this area, pre-pregnancy planning. And then psychiatric illness as well, a huge group that I think deserve their own pathways and their own systems, and those with eating disordered histories. So really what I think are the key priorities for implementation of a successful clinical care model is that there's community involvement and targeted promotion of health in general and coordination of those obesity services. The red that there is really, I guess, at a tertiary level, reconfiguring specialist services for optimal effectiveness and ensuring access to guidelines, protocols and decision aids, developing information and community technology systems so that we can talk between each other, so that collaborating with other groups in Sydney or across the country or beyond on the international stage, that we can actually share data, and also that we're fostering really good, sound, basic and clinical research from what we do and the questions that we ask. And so to summarise, the characteristics of an ideal clinical obesity service is identifying the breadth and depth of the obesity problem first and foremost, focusing on prevention, identification and then treatment, not just the latter, and data-driven services with integrated care between all the service providers in a fluid and a continuous manner. And then beyond that, being able to evaluate what we do and hence being able to publish it really of hard outcomes, but also patient reported outcomes and experiences, and hopefully showing some cost effectiveness.